Hello, my name is Nikolai Yusupov. I am an instructor coordinator, paramedic, and a registered nurse. And in this video, I would like to talk about how to best position your patient for optimal BVM ventilations. Now, if you take a look at this technique, what you see the provider is doing is head tilt chin lift, but in reality, what he's really doing is head tilt, mouth closed. And if you're performing this technique in the field, you're essentially performing the wrong technique. Now, it's unfortunate that a lot of EMS books show the wrong technique, and a lot of times the back of the chapter never has any references for where did they get the techniques that they employ all these procedures from. Now, my goal in this video is to show you peer-reviewed evidence-based studies that will essentially support the techniques that I'm going to show you. When initially this technique was shown by Peter Safar, the way he was demonstrating this technique is he was grasping the lower mandible and lifting the jaw forward, as you see in this schematic drawn here. This was taken from the actual Peter Safar's study, and here you see Peter Safar pictured as the operator, and he's grasping the mandible and he's lifting it forward up towards the ceiling. And what's the purpose of this? The purpose of this was to essentially lift the mandible so that the tongue is no longer blocking the laryngeal inlet. We know that the genioglossus muscle of the tongue is a very big muscle, and when the patient is unconscious, it will essentially relax and fall backwards, occluding the laryngeal inlet. And thus the operator needs to lift the jaw upwards. It was never this technique, head tilt, mouth closed, that you saw in that video prior. It was never done this way. And all these books, they essentially incorporated the utility of this wrong technique. Now, let me show you how this technique was originally performed in the study.
The mandible is grasped at the midline with the left hand and pulled forcefully upward. The pneumograph shows tidal volumes of 2,000 milliliters and more.
Now, as you clearly saw, Peter Safar was essentially lifting the mandible upwards so that the lower teeth are in front of the upper teeth. This is how you know your maneuver is effective. Now, in this video, I'm not going to advocate that you put your thumb in the patient's mouth. I'm going to outline the technique that he showed in his study called the triple airway maneuver. And that's the technique you would want to employ in the field for your patients. I would like to talk about the objectives for this video presentation. First, I would like to present airway skills, which are evidence-based and are based on peer-reviewed studies. And often in EMS literature, we see a lot of chapters are written with no peer-reviewed sources that are cited in reference, and essentially the skills that they demonstrate are the wrong skills. They show you the wrong technique. So I'd like to remedy this in this video by showing you skills which are evidence-based and they're based on studies. Here I will describe the findings of Peter Safar's 1959 study titled Upper Airway Obstruction in the Unconscious Patients. During this time, Peter Safar was essentially chief of anesthesia in Baltimore City Hospital, and this is where he studied a lot of the patients and a lot of these volunteers, and based on that work that was conducted in the late 1950s, we know now what's the best technique for essentially maintaining a patent airway. I'm also going to describe the findings which head and jaw position produced the optimal patent airway. I'm going to outline and thoroughly explain Peter Safar's triple airway maneuver, and that will be the technique of choice going forward anytime you have to manage someone's airway. I'm also going to demonstrate triple airway maneuver on an adult human skeleton. Now, who was Peter Joseph Safar? Peter Joseph Safar was essentially known as the father of modern cardiopulmonary resuscitation, or CPR. He was one of the inventors of CPR. He also created the first paramedic ambulance in Baltimore City Hospital, and there he served as chief of anesthesia, where a lot of these studies were conducted. He was also a creator of the first intensive care units in the same hospital. So he was one of the pioneers, and a lot of this groundwork was essentially accomplished by him with these studies where he utilized volunteers. And this is essentially a landmark study from where we now know how to manage someone's airway. This study was conducted in 1959 and it was titled Upper Airway Obstruction in the Unconscious Patients. Here you see all the authors of the study. Now, what was the purpose of the study? So the purpose of the study was to find airway patency, and they studied 80 anesthetized patients who were spontaneously breathing. They were trying to find if the obstruction due to flexion of the neck occurred also in the unconscious patients whose muscles were not completely relaxed. And essentially, the muscles they want to examine is your tongue muscles, essentially the genioglossus muscle, which is the big muscle of the tongue. And when you are unconscious, the muscle will relax and the tongue will fall backwards, essentially occluding the laryngeal inlet. And they placed these patients in various positions in both supine and prone positions, and then they studied the patency of the airway in each position respectively. What's important to note in the study, they did not use curare or curare-like drugs. For example, succinylcholine, which is a paralytic agent. If a patient receives such drug, it will paralyze the patient fully, including the diaphragm and all the muscles of the respiratory system. So they did not inject these patients with curare drugs to paralyze them. However, they did give patients cyclopropane, which is essentially anesthetic gas. And what this does is it will sedate the patients. However, they did not lose their respiratory drive, so they were still able to breathe spontaneously. Here you see a chart of the 80 patient study. You see their age, which ranged from 0 to 90 years old. They employed 13 men and 67 women for a total of 80 patients. And you see their average weight in pounds, which important to note is that they also had obese patients in their population. And we will soon find out that when the patient is obese, it's very hard to maintain their airway patency. And essentially, someone who is obese is known as a difficult airway. Now, the positions they placed the patients in are outlined here. So first, let's start with the supine patient. So in the top picture, you see picture A. It was essentially neck was flexed when the patient was in a supine position. When neck is flexed, your chin is tucked down. And what happens is in this position, the tongue will fully occlude your laryngeal inlet. In position B, head was in mid position. So essentially, this may be known as the sniffing position to some of you. C, the neck was extended. So they extended the neck in the supine position. D, with the extension of the neck, they also had the forward displacement of the mandible so that the lower teeth were in front of the upper teeth. Very important to note, the position D will later be known as the triple airway maneuver, which I will outline in this presentation. At the bottom, you see same position studied, but only in the prone position. So in the picture E, you see the neck was flexed. So chin tucked, again, tongue blocking the laryngeal inlet. Position F, head in mid position. G, neck extended. And H, you see neck extended plus forward displacement of the mandible in the prone position, which essentially the triple airway maneuver. The way they achieved these positions, they placed padding and they used the pillow to essentially elevate the patient's chest in order to get access to the mouth with the bag valve mask. So what they did in the study is that they employed a tight-fitting face mask. They would place this mask on the patient's face. And here you see an anesthesia circuit connected to the anesthesia bag. And what they would do is they would observe this bag for inflation when the patient was spontaneously breathing. And they would record their airway parameters as I would outline them next. Here you see how it was actually conducted in the study. You see a tight-fitting face mask, which is placed on the patient. And the Peter Safar, essentially pictured here, would look at the bag, and pneumograph is pictured showing you the tidal volumes. Now, when the anesthesia bag was moving freely and there was no noisy breathing, they would record that the airway was open and patent. When the anesthesia bag was moving in the presence of noisy breathing, such as snoring, the recorded airway is partially obstructed. And when the anesthesia bag was not moving at all, or no exchange was audible with the patient's chest and abdomen were moving, they recorded the airway as obstructed. Next, we see the chart of their findings. And first, I would like to outline the columns here. We see in the airway column all the head positions I talked about in A, B, C, and D. The next says A plus OPA, B plus OPA, C plus OPA, and D plus OPA. What does that entail? That entails essentially the position of the head, A, plus they placed an oral pharyngeal airway, an OPA. Same thing for B, C, and D. The next column shows you number of patients who had an obstructed airway. And obstructed airway, we said the airbag was not moving freely, so they recorded as obstructed, and we see the percentages of the patients. The next column we see partially obstructed. That means that the airway bag was moving, but you heard some noisy breathing such as snoring. And again, we see the number of patients and the percentages of that. And the final column to the right, we see an open patent airway when the bag was moving freely with no noises. We see number of patients and the percentages. And I'd like to examine each position individually and go over the findings that they obtained. Very important thing to note is that when the neck is flexed, so chin is towards the chest, the airway was obstructed in all patients, both in supine and prone position. And this is important to know that it was with and without an artificial oropharyngeal airway in place. So that means that when the chin is tucked and your tongue is essentially occluding the laryngeal inlet, regardless, even if you put an OPA there, it will still not produce a patent airway. And here we see when the neck was flexed, chin down, how many patients had an obstructed airway without an OPA. Without an OPA, all 80 patients or 100% had an obstructed airway. So when they placed an OPA in the same position with chin tucked, you only see that 78% had an obstructed airway, and that was 98%, and 2 had partially obstructed airway, so you heard snoring respirations, which was 2%, and 0 patients had a patent open airway with freely moving anesthesia bag. So it's a big misconception that people think, well, you place an OPA, so that maintains your airway, and that's false. And as the study showed, right, none of the patients who had this device in place and the chin tucked had an open patent airway. And there was another study by Peter Safar, which was published in New England Journal of Medicine. They found that even with the use of an artificial oropharyngeal airway, the pharynx is not kept patent unless both hands of the rescuer are used to hold the head in extension and support the mandible. This is essentially placing the patient into the triple airway maneuver. So by itself, an OPA is not good enough, and it will not produce an open patent airway. So you need to get rid of this myth and stop thinking that just placing an adjunct will provide a patent airway patency, which is false. And what this study showed is that the most common type of obstruction, which is frequently overlooked, and that's the obstruction of the oral pharynx by the relaxed tongue, which is pushed against the posterior pharyngeal wall when the neck is flexed and the mandible is not supported. So we know that the tongue has the genioglossus muscle, which when the patient becomes unconscious will relax, and this will facilitate tongue falling backwards, occluding the laryngeal inlet. And if we do not support the mandible and essentially lift it up, we cannot relieve the obstructions that's caused by the tongue when the neck is flexed. Here we see a cadaver which shows you the tongue, and here I am specifically pointing to the genioglossus muscle, which is attached to the mandible directly. And you see a sliver of epiglottis, and as the tongue relaxes, it will pull back, including the laryngeal inlet. Here we see Peter Safar essentially holding the mask and observing the anesthesia bag as the patient is breathing spontaneously. And what's important, again, as I said, that even with the artificial oropharyngeal airway, or OPA, in place, flexion of the neck pushed the tongue against the posterior pharyngeal wall between the tip of the airway and the laryngeal interns. And here we see an X-ray where the patient actually has an OPA in place, and still his AP diameter shows you that there's still occlusion to his pharynx. What's important to note is that this study was performed on real live patients who are spontaneously breathing, and we know when the patients are unconscious, their tongue, which essentially shown here, the genioglossus muscle, which is attached to the mandible, will relax and fall backwards, occluding the laryngeal inlet. They did not use these airway test trainers to conduct their study, and that's important because these airway test trainers do not have tongue that will relax and fall backwards. And if any of you use this particular model, you know that even if I utilize the wrong technique to ventilate this test trainer, I'll still get chest rise, irregardless of the way the head of this mannequin is positioned. And I'll actually show you a video later on where I specifically employed the wrong technique on this test trainer, and sure enough, I had chest rise. So on a real patient, you will not see chest rise until you position the head appropriately and relieve the obstructions of the tongue by elevating the mandible. Now, this is what the study demonstrated, and I have the 2 x-rays with OPA and without an OPA, showing that when the neck is flexed and the chin is tucked, the tongue will essentially occlude the laryngeal inlet in both the patients without an OPA and in the patients with OPA in place. And here we see the X-ray showing you that the AP diameter is not optimal for best ventilatory support and essentially chest inflation, lung inflation for this patient. What happens when you place a patient in chin tucked position? Essentially, the airway resembles this kinked endotracheal tube that I have pictured here on the right. And as you could see, when your airway is kinked like so, it doesn't matter, even if you have an OP in place, no breaths will facilitate chest rise, and no breath will go into the patient. So besides placing an adjunct, you need to essentially lift the mandible upwards to relieve said obstruction. The next head position they looked at is head in mid position, facing straight upward. If we look at the obstructed category, we know that even with the OPA in place, 23 patients or 29% had an obstructed airway. In the partially obstructed category, 41 patients or 51% had a partially obstructed airway. And in the final column, the open airway, with the OPA, only 16 patients or 20% had paid airway. So is this the position you want to employ for your patients? No. With these results, it tells me that head in the sniffing position or head in mid position does not give me a fully patent airway, and thus this is not the best position to employ for my patients. The next position they looked at is neck extended at the atlanto-occipital joint or chin up. And if we look at the obstructed column, 0 patients or 0% had an obstructed airway, which is good. It's better than the airway position before. But if we look at the next 2 columns, we see that partially obstructed with the OPA, we had 10 patients, which is 12%, and open airway was in 70 patients, which is 88%. So is this the best position to place our patients? No, because we clearly see that even with OPA in place, 10 patients or 12% had an obstructed airway. And I want the best position and the best optimal position to provide ventilations. I don't want second best position. One of the important things that they note in the study is that with the extension over the atlanto-occipital joint when the patient was in the supine position, they only had 50% of the patients who had the patent airway. And if you ask me, 50% is not a good enough of a number for me to employ a technique in the field. I want the best success and I want the best technique from the start. So what they say the other 50%, in addition to extension of the neck over the atlanto-occipital joint, also required forward displacement of the mandible or placement of an oropharyngeal airway or both. So to achieve airway patency, besides the extension over the atlanto-occipital joint, you had to lift the jaw and place an OPA. Well, makes sense to me. I like to explain what I mean by the atlanto-occipital joint. So the occiput articulates with the atlas at the atlanto-occipital joint, shown here at A, and then atlas articulates with the axis at the atlantoaxial joint, shown here as B. Atlas is known as C1 and axis is known as C2. Atlas will support the occiput. So like the atlas who holds up the globe, the atlas supports our head, and axis, as you know, axis on the globe facilitates rotation. So axis C2 will facilitate rotation of head side to side. And here is where the names come from. C1 is the atlas. Essentially, atlas holds up the globe and C1 holds up the skull. And C2, being the axis, allows us rotation of the head side to side. Here, I'm actually utilizing a mannequin to show you all these landmarks, which will be important going forward when outlining the steps of the triple airway maneuver. Based on the study that I just discussed by Peter Safar, first I'd like to show you what an OA joint is, or atlanto-occipital joint. So if you come over here, you'll see that's the skull, that's the occiput, right? And below of it, we have the first vertebra, or the C1. And as you guys know, C1 is the atlas. It holds the head up, right? If you remember from the picture, it's like an atlas that's holding the globe up, which is the head. And below it is C2. This is the axis, right, for head rotation. So the one we cared about is the atlanto-occipital joint. So it's the occiput and the joint that articulates here, right, with the skull. And when we perform head tilt, this is the joint that we're going to extend, right? So I'm showing you here. And this is in patients that do not have cervical spine injury, so no injury to their neck. Now that you're familiar with the landmarks, let's look at the final position, with the neck extended at the atlanto-occipital joint plus forward displacement of the mandible. And this later will be known as the triple airway maneuver that Peter Safar outlined in the study. So once you place the patient in position D and you place an OPA, we'll look at the first column. So 0% of the patients had an obstructed airway. Next, we look at the partially obstructed. Only 2 patients, or 2%, had a partially obstructed airway, and that means that when the anesthesia bag was moving, there was some sonorous respirations. And then in the final column, we see that 78 patients, or 98%, had patent open airway. And out of all these positions, this position proved to be the best position to place our patients in to achieve open and patent airway. Now, here's a chart with all the positions studied in the supine position, and I want to point your attention to position D plus an OPA in place. We know that 0 patients, or 0% of the patients, had an obstructed airway. 2 patients, or 2%, had a partially obstructed airway, and 78 patients, or 98%, had a patent open airway. Thus, out of all these positions, the most optimal position to place your patient to provide BVM ventilation was essentially position D, which will be known as triple airway maneuver. And the way it's performed is you're going to extend the patient's head over the atlanto-occipital joint, elevate the mandible so that the lower teeth are in front of the upper teeth, and insert a properly sized NOPA. Once you have all those 3 things in place, this will provide you with the best airway patency that you can achieve. And as someone who is an EMS provider, I want to employ the best technique from the start. I don't want to employ a bad technique and then reposition the patient, again going to bad technique that's shown in all these EMS books with this EC clamp one-handed technique. I want the best technique from the start. Thus, if you want to utilize the best technique, which was validated by peer-reviewed studies using 80 anesthetized patients who were spontaneously breathing, the choice is clear. You want to employ the triple airway maneuver, pictured here with an OPA in place. Now, the way this technique is performed, you're going to essentially perform extension over the atlanto-occipital joint, and you're going to perform forward displacement of the mandible. The way I know that it's done correctly, as I stated, the lower teeth are going to be in front of the upper teeth. Here we see x-rays that they took in the studies, and I want to point your attention into the AP diameter. So we note in picture C and D, right? And specifically in picture D, the x-ray shows that the neck extended plus forward displacement of the mandible, the anterior posterior diameter, or AP diameter, of the pharynx is increased. And I showed that with this yellow line, and we clearly see that in position D, the forward displacement of the mandible give us a much bigger AP diameter as opposed to picture C, B, and A. Here we see the same positions, but patient has an OPA in place. And again, in position D, with the forward displacement of the mandible, you see the greatest AP diameter that's achieved. The way they achieved this position and the way these x-rays were taken is that the operator placed his thumb in the patient's mouth and then proceeded to lift the jaw upwards, as you see in the schematic. And then these figures, these x-rays, were taken with the operator's hand still in the mouth. So that hand you see, that's the operator holding the mandible in place. Now, I am not advocating that you perform the jaw lift procedure in the field. I am, however, advocating that you're performing the triple airway maneuver in the field, as you see pictured here. And here I want to point out, why is this an effective technique? Why do you want to perform the triple airway maneuver? So not only was it validated by all these studies, here we actually see a real cadaver, and I want to point your attention to number 7, which is the mandible, and it's connected to number 8, which is the genioglossus muscle, the big muscle of the tongue. So the genioglossus is directly connected to the mandible. And when the patient becomes unconscious, this genioglossus muscle of the tongue will relax and the tongue will fall backwards, occluding the laryngeal inlet. And if you take a look at number 17, which is the laryngopharynx, and number 18, which is the epiglottis, these will fall back, and essentially you will close off the air going into your trachea. So it's very important that we control the mandible and we lift the mandible upwards, thus displacing the tongue and lifting it off the laryngeal inlet to provide us a pain open airway. And here I have two more pictures of the cadavers, and it's important to see the size of the tongue, its connection to the mandible, and how, if it's relaxed and it falls backward, how easily it can occlude the laryngeal inlet. And both of these diagrams clearly show that. Here's another close-up view. Again, I show you the size of the tongue, the genioglossus muscle, and the laryngeal inlet. Again, we need to perform a good jaw lift in order to relieve this obstruction in unconscious patient. And as the findings of the study state, you see a comparison in X-ray C and D, and it shows that the forward displacement of the mandible greatly increases the AP diameter of the pharyngeal airspace, because the tongue, which is the big muscle in your mouth, which is attached to the mandible, as I just outlined here, right? The genioglossus muscle attached directly to the mandible is lifted away from the posterior pharyngeal wall, thus allowing your laryngeal inlet to be open and facilitate air to come in when you're ventilating someone with a BVM. Here we see Peter Safar in the study, and what he's going to show you is when you perform the head tilt jaw lift and you ventilate someone, that the air actually goes in, and you'll see those tidal volumes registered on the pneumograph. And then he's going to essentially place the patient back with the chin forward position, and you will see no air going to the lungs of the patient. Right. So you see, right, he's performing a jaw lift, the mandible is elevated, and you see a good chest rise, and the pneumograph is recording good tidal volumes. He then goes and positions the patient inappropriately. So now the tongue is occluding the laryngeal inlet, and the jaw is not elevated, and you notice there's no chest rise. Once he repositions, elevates the mandible, again, you have chest rise, and pneumograph shows you good tidal volumes. So again, this was very important to show you that it's not only important to place the patient correctly, you also must elevate the mandible to relieve that obstruction that's caused by the tongue. Also, 50 out of 80 patients were studied in the prone position, and what they found is that in all 50 patients, the prone position was as often or slightly more often obstructed than in supine position. So prone position did not show any benefit over the supine position, and supine position was essentially a better position for airway patency. Here we see a chart for the prone position. I'm just going to take you to the open column all the way to the right, and at the very bottom we see the extension plus support of the mandible plus an OP in place. And when the face was downward, 42 patients or 84% had patent airway, and when the face was to the side, 44 patients or 88% of the patients had patent airway. So not of a great increase, and actually the supine position shows us better numbers. Here we see two x-rays in the prone position, and you can clearly see in the first image when the chin is tucked how the laryngeal inlet is blocked, and we see how the epiglottis is occluding it. To the right, you see an x-ray image once the head was extended, also in the prone position, and we see that the airway patency was regained. So same sites of obstruction as in the supine position. They know that the extension of the neck causes the opening of the nasopharyngeal and oropharyngeal air spaces. And we see that the AP diameter is increased here in this x-ray. The x-ray images in the study data showed that the prone position does not prevent swallowing of the tongue, and the tongue does not simply fall forward. Rather, the site, the mechanism, incidence, and degree of pharyngeal obstruction is similar in the prone as in the supine position. So it was a misconception by providers who thought that placing the position in the prone position would essentially make the airway more patent and relieve the obstruction of the tongue. But we don't see that on the x-ray images shown here. And it's a false belief of airway obstruction due to swallowing of the tongue is prevented by placing the patient in the prone position. So never place your patient in the prone position in hopes that this will relieve airway obstruction. And these x-rays shown consistently that the prone position is not at all better for airway patency. There is, however, some major disadvantages to the prone position. Well, first of all, the face is poorly accessible, so you cannot really see if patient is developing cyanosis. That's the bluish tinge around the mouth, or sometimes it's known as circumoral cyanosis. And you cannot recognize foreign matter. If the patient were to vomit, they can easily aspirate from that position. It's also most impossible to perform BVM ventilations in the prone position. And in the study, what they did was they placed a pillow to elevate the chest. But if your patient is lying prone on your stretcher, it will be extremely difficult to place a BVM, create a good seal, and provide good ventilation. Also, for a spontaneously breathing patient, it's much more difficult for the patient to breathe because the patient must lift more of their body weight. So if the patient is obese and you place them in a prone position, for them to get good chest excursion, they have to lift more of their body mass up and down. And again, it becomes much more cumbersome in the prone position. Here we see a summary of supine versus prone position, and I want to point your attention at the very bottom of this chart. We see essentially the triple airway maneuver, extension of the atlanto-occipital joint, forward displacement of the mandible, and the placement of an OPA. And patients who were placed in supine position, all 50 patients or 100% had open patent airway. And in the prone position, only 46 patients or 92% had patent airway. Thus, supine position proved to be more effective in achieving open patent airway. They also note that the obstruction was more common in obese patients. Well, why is that? Well, obese patients have more soft tissue in the airway, and this is one of the reasons they develop obstructive sleep apnea. And a lot of them may need CPAP at night to open the air passages to facilitate ventilation and air movement. So because of that, obese patients have a much higher incidence of obstruction, and they're also much harder to ventilate. They note in this study that an unconscious person who does not need resuscitation, so does not need CPR or ventilation, should be placed in a lateral position, which facilitates drainage of liquid secretions through corner of the mouth. And we know this position if you have someone who is inebriated but does not need resuscitation. We often place them in lateral recumbent position to facilitate drainage of liquid secretions. Now, I want to outline here the triple airway maneuver. And this is the technique that you're essentially going to employ. The operator will place themselves at the head of the patient, and they're going to find the mandible, specifically the ascending rami. And what they're going to do is lift the mandible upward so that the lower teeth are in front of the upper teeth. They will then use their thumbs to keep the mandible from closing, as you see pictured here. And in this study, the operator was essentially providing mouth-to-mouth ventilation, but you will be doing this with a BVM device. This is how it looked on the actual patient. So the operator placed themselves behind the patient. They found the ascending rami using their index fingers. So it was usually by the earlobes. Once they locate this landmark, what they're going to do is they're going to lift the mandible upwards towards the ceiling. They will lift the jaw upwards. They will then use their thumbs to keep the mandible from closing. So the index fingers are facilitating jaw lift, and the thumbs are facilitating from keeping the mouth and lips from closing. Here's a side view of all of this in place. In this study, you're going to see Peter Safar doing this technique, but he's providing mouth-to-mouth ventilations. And in the field, you're not going to be providing mouth-to-mouth ventilations. You're going to be using BVM to facilitate positive pressure ventilation.
Now comes the alternate method, or two hands jaw lift method. Both hands grasp the angles of the mandible and pull forcefully upward. The thumbs retract the lower lip to prevent obstruction by the lips. Air leakage through the nostrils is prevented by the rescuer's right cheek.
And to me, this was important to show, because when I saw this originally, I realized a lot of the techniques that are shown in EMS books are the wrong techniques. And when this study was performed, they employed the techniques which provided optimal patent airway. And it's important to see how this was done in the initial phases, and how due to making material less and less complicated, you essentially dumbing down to the point where techniques become the wrong techniques, and you start using not the best methods of managing someone's airway, but you're starting to employing very poor methods in managing someone's airway. In the discussion section of the study, they note, with the chin pushed downward, the base of the tongue pushes the base of the epiglottis against the false chords. And this is what I was describing. Once the tongue is relaxed, the genioglossus muscle relaxes, and it will occlude the laryngeal inlet. This laryngeal occlusion may be relieved by tilting the head backwards over the atlanto-occipital joint and displacing the mandible forward so that the lower teeth are in front of the upper teeth. This will stretch the front of the neck and pull the pre-epiglottic tissues anteriously. And this is what we want to achieve when we provide the triple airway maneuver for our patient. What's important to state is that hard facts do not change over time. We knew how to properly position a patient in 1959, and these landmark studies have demonstrated the optimal position. So with all the time that has passed, what happened was we stopped employing the best techniques and we started employing the wrong techniques, for the simple matter of dumbing down the material and making it more simpler for the lay person or the lay rescuer. And we should revert back to employing the techniques that were validated with these peer-reviewed studies. And I'll say it again, hard facts do not change over time, and we should be employing the best techniques that provide the best airway patency from the start. I don't want second best technique when they come to the patient. I want the best technique from the beginning. And that technique proved to be the triple airway maneuver, which was outlined in the 1959 study. Here I'm going to show you how to perform the triple airway maneuver on the skeleton. Here we have an adult human skeleton, and I'd like to go over some of the important components that you need to know for airway management. Here we have the skull, and here's the upper jaw, which is known as the maxilla, and here we have the lower jaw, which is known as the mandible. The mandible has the following components. This portion here is known as the base of the mandible. This entire portion here is known as the body of the mandible. Here we have the angle of the mandible, and this portion here is known as the ramus. And the one that we need to be familiar with is the ascending ramus when we essentially perform the jaw thrust. Now, below the skull, we have the cervical vertebra, and the one that we need to be familiar with is C1, which is known as the atlas, which is essentially like the atlas that was supporting the globe. And atlas here is the C1, supports the skull. And below that, we have the C2, which is the axis. And that's responsible for rotation of the head from side to side. So when we perform the triple airway maneuver, as was demonstrated by Peter Safar, he essentially performs an extension over the atlanto-occipital joint, which articulates the base of the skull with C1. So it's extension of the head. Then what he says you perform is elevation of the mandible by grasping the ascending rami, and essentially you lifting the mandible up to the ceiling. How do you know you completed the task? You know that you completed the task when the lower teeth are in front of the upper teeth. And this would facilitate an effective jaw thrust maneuver. And you use your thumbs to essentially keep the mouth open. And this is the procedure you're going to perform when you're performing the triple airway maneuver with all your adjuncts and back valve mask device. Now, since I have the skeleton out, what is the proper technique of sizing an OPA? So the proper technique in sizing OPA is from the central incisors to the angle of the mandible. So if I took this OPA, you notice that from the central incisors to the angle of the mandible, it far exceeds the lower jaw. So this would be the wrong size to employ. If I use this one, you notice, right, from the central incisors to the angle of the mandible, this would be the appropriate size for this patient. So this is how I would size an OPA properly. Thus, in my conclusion, I want to say you want to employ the triple airway maneuver whenever you ventilate someone. And what you want to perform is extension over the atlanto-occipital joint, forward displacement of the mandible, and place an appropriately sized OPA and ventilate someone with a BVM device. When you employ all these three maneuvers, you will achieve the best and the most optimal patent airway for your patient. Thank you.